policy talk that I think the Integrative Health Institute has sponsored. And just for those of you who are new faces here, welcoming you, what we're trying to do with this symposium series is not just lecture at you, but have about a 30 to 35, 40-minute presentation, which will then, we hope, always, and always has, it seems, prompt some good debate, back and forth conversation afterwards. This series of talks is supported by the Provost's Office of Research, and our goal really in doing these symposiums is to bring diverse faculty, students, staff together, all of whom have an interest in integrative health, integrative medicine, however you conceptualize that, in order to really build a collaborative research community. That's the specific focus. But this is our first policy talk. And of course, there are a lot of folks working on campus in policy. I know there's some folks here who came specifically to hear about the Affordable Care Act. It's obviously a very hot topic around the country right now, very timely. So without more ado, Michael, I welcome you to educate us all about it.
Okay, very good. Thank you, Mark. Usually don't use this microphone, but we're going to tape it. So, well, thank you and welcome. Is this people's first time at the Soda Building? Or? Yes. Good. Well, welcome over here. And our building is a couple years old, and this is where the Department of Preventive Medicine is. There's some other administrative units. And, this is where my home is, so this is convenient for me. So thank you for inviting me here. So I wanted to speak a little bit about the Affordable Care Act, and less about integrative medicine as it relates to that, because to be quite honest, two things that I learned, but there's not too much in there about it, number one. And number two is that I certainly wasn't an expert in it to be able to speak real informatively about it, but I have spoken to others, and we're going to try to bring in some of the new information that the Act provides with respect to integrative care. So I apologize for having too many slides here. I cut quite a few of them out, but I wanted to just go over some of the basics of the Affordable Care Act, help maybe get rid of some of the myths that you might have, and then devote quite a bit of time, as Mark said, to answer some questions. But it was passed in 2010 after a very contentious political battle in Washington, and barely signed into law with just the smallest of margins, based in part because of the complex laws in the Senate about how you pass laws, and the number of senators you need to vote for it in order to get something passed. And anyway, it did pass, and has been, the contention and the controversy has not waned at all. In fact, in many respects, it's gotten worse. And as you know, from watching what's going on in Washington right now, it's again at the center of the debate. And it's quite perplexing to understand why. In one respect, if you go back in the history of healthcare reform in the United States, it's not too surprising that just about every president, going back to Teddy Roosevelt, has tried something around universal healthcare efforts and reform, and just about everyone was not successful, even though there were some smaller victories along the way. But certainly the Affordable Care Act is important. It's probably the most significant piece of policy legislation in healthcare since the passage of Medicare, which is health insurance for the elderly. So I'm just going to sort of jump through some of these as quickly as I can, and talk a little bit about what is going into effect. The bill was almost 1,800 pages. I helped write parts of it, so I know what's in little pieces of it. I've read the whole thing, and my students actually have to read the whole law. They say they do. I don't know if they do. But in any case, one of the things that it does is it expands health insurance coverage. And we have about 51 million uninsured people in the United States, about 6.5 million here in California, and about 2 million in LA County. And those of you who work at the county system understand this on a day-to-day basis because of the number of uninsured people we have in our county healthcare system. So this law and the passage of this law has a lot of implications for what we do here in LA. So in beginning of January 1st, 2014, the Medicaid program will expand to essentially include everybody, just about everybody, up to 138% of the federal poverty level. So if you're familiar with the Medicaid program, you know that it is an enormously complicated program. It's not enough just to be poor to be on Medicaid. You have to fall into one of 157 different categories of eligibility. And we employ all these people to figure out if somebody's eligible, they're going to be blind, they're going to be pregnant, whatever. All these different categories. So a lot of that's going to go away and get replaced by a much simpler system in which a person determines eligibility based on their adjusted gross income. Now there are some exceptions we'll talk about in a moment. The most important one is that if you're an undocumented immigrant, you're not eligible for any of these expansions, anything I'll be talking about. Emergency Medi-Cal, that some of you are familiar with, you would still be able to get if you're not an undocumented immigrant. You walk into the emergency room, or a pregnant woman will be able to get, continue to get Medi-Cal. But the big change here is that we've expanded Medicaid to include about just about everybody else under 138% of poverty. The important thing for us at the county system is that what this does is that it expands Medicaid to the low-income adult, unattached. That is, they don't have kids, they don't have dependent. So, I mean, that's, those of you who worked in the homeless clinics know that it, in spite of the poverty, it's very difficult to get a homeless person on Medicaid in California because they're a single adult, they don't fit into one of those categories. Now that's all changing. So, that's the biggest change in terms of expansion. Second thing is probably you heard a lot about in the media is the establishment of these health insurance exchanges. These essentially are new marketplaces of insurance coverage, private plans that have been established for people who are not poor enough to go into Medicaid, but will be able to get some sort of a subsidy to help pay for part of the premiums. I'll go into that in a moment as well. So we estimate about 3.35 million Americans potentially are eligible for one of these two programs. And in California, we think it's about between 3.5 and 4 million people who could become eligible. And that doesn't mean they're going to be enrolled tomorrow. We have about 18, so as of yesterday, we had about 18,000 people enrolled in the new program that we've established. But it's going to take a while to ramp this up and a lot of investment of time and energy to get folks involved. So, so we think that this slide here was established by some colleagues at UCLA, and this here shows that, well, right now, some of you may know this, but there's quite a few uninsured people already in California who are uninsured and eligible for Medi-Cal. They're not enrolled for lots and lots of reasons. So we think as many as 880,000. Most of those are children who are eligible for Medi-Cal right now and are not enrolled. We think another 1.2 million will become eligible under the new Affordable Care Act provision under Medicaid. Over here is the number of people who will be eligible for the exchange with some level of subsidy. What I mean by that is that they are in an income category between 138 and 400% of poverty, which would make them not only eligible to go into these exchanges, but also they'd be eligible for some level of subsidy to help reduce the price of the premium. And that varies by their income. We think another almost 1 million people will still be eligible for these exchanges, but their incomes will be high enough where they'll still be eligible to go into the exchanges, but they won't be eligible for a subsidy. And then we think in California about 1 million are undocumented and will not be eligible for anything. One of the provisions of the Act that was included near the end of the negotiation was a provision that said undocumented immigrants are not eligible for any of these. In fact, they're not even eligible to go into the exchanges that they decided to pay the full cost. So that was in the Act, and so that creates tremendous challenges for those of us who are running the county healthcare and safety net, because we've got to figure out not only to take care of the people who are going to come into the system, but also all the people who are not going to be able to get insurance. So a little bit more about the Medicaid expansion. Again, it covers these folks up to 138% of the federal poverty level. And the important thing is that until 2021, the federal government will pay 100% of the cost of these new patients. Right now, in the regular Medicaid, we have a shared situation where the federal government pays about 57%, and each state pays 43%. And right now, under the new program, anybody that comes under the new rules, the federal government will pay 100% of the cost. So it's a good deal until 2021 for the states, because they can expand, and the federal government will pick up the entire cost of the expansion. So this is an important change. Now, when the law was written, and this is important, less important for us in California, but for nationally, when the law was written, the law said that if you want to continue, this was to the states. If you want to continue your old Medi-Cal program, every state got a certain amount based on the percentage of the program that the federal government was going to pay for. So that varied by state. But if you wanted to keep your old money, the regular Medi-Cal program, you had to agree to take the expansion, the expanded Medicaid dollars. And the Supreme Court struck that down. They said that it was coercive, and so right now the states do not have to take the new expansion. I think right now we know about 19 states that have agreed to take the new money, and the rest have not. They tend to fall along political lines. I think I have a map that shows this. If not, I can send it to you. Here it is. Yeah, Mark.
So I don't want to interrupt, but
Sure.
so if they choose not to expand,
Yes.
do they not get the federal government paying 100% from what they already have?
Yeah. No, but the 100% only covers
The expansion.
the expansion. So if they're not getting the expansion, they don't get the federal dollars. Now, right now, this is changing pretty quickly. These are the states. The blue states are the ones that have already gone ahead and agreed to take the expanded Medicaid programs. The light blue ones are the ones that are debating it, and the orange ones here are the ones that said they're not going to take it. Now, this is changing quickly because, and it's interesting politics, because a lot of these states are run by governors who have publicly said we're not going to take the money, but their Medicaid directors are in Washington negotiating these waivers that allow the money to come to them. So it's a little weird what's going on, including Rick Perry from Texas is one person who said, well, I'm not going to do it. He said the Affordable Care Act is criminal and all this other stuff. And while he's doing that, he's actually negotiating his Medicaid. But so we'll see what's happening. What's happening in a lot of these states is that they're having the same problems we are. They have large numbers of hospitals that have really high uncompensated care costs, and their hospitals, CEOs, the health plans are going to the governor saying, we got to do something about these costs. It's just out of control. So they're getting pressure from a lot of different sides. So the health benefit exchange, again, is a new market for those in the individual market. And, you've heard the president say, he was right, that for most people in the United States, the Affordable Care Act will have very little impact. And the reason why is because most of us get our insurance through our employers. And the Affordable Care Act has very little to do with what employers provide to their employees. And the Senate version of the Affordable Care Act, if not passed, it would have had a much more of an impact. But on the one that did pass, it's very minimal. I'll talk a little bit about what those are. So this new marketplace you've heard about, we call it in California, we call it Covered California. This is essentially, there's 9 plans. They vary by region of the state. And they are all have to agree to a certain level of what we call 10 different essential benefits that they have to offer. And these are all available, essentially, you can enroll online. You can go to the website right now and you can play around with it and see how it works. Again, this is a state option. The states do not have to set up these health exchanges. 16 have done it or are doing it. And if you are in a state that is not doing it, the federal government is setting one up. And then the people in those states can then go onto the federal website and try to get into one of these health insurance plans. So, and there are different tiers of coverage, just like if you work for a company and you go in and there's different plans. You can choose Kaiser or USC plan or whatever. It'll be something similar in which you would be able to choose among different plans, and then within those plans, you can get different benefit packages that dictate how much you're going to pay every month, what the co-payments are going to be, what the deductibles are going to be. But the benefit packages pretty much all have to be the same. Now, the important thing here is that the subsidies in the form of tax credits occur for those with these incomes between 138 and 40% of poverty. As an example, 400% is quite high. You think it's for a family of four, it's about $90,000 a year. Now, the subsidy at closer to this level is pretty small. As you get closer down to 138, it's almost 95% of the premium. So, depending on your income, it can really significantly reduce the size of the premium that you have to pay every month. So, that's all determined. And the way it works, it's a little complicated. One of the problems with this act is really complicated. It's a tax credit, which means that you buy health insurance, you agree to one of these plans, and the federal government sends a check to the insurance company for the subsidy level of the, so let's say your subsidy is $150 a month. The federal government will then send a check for $150 a month to the insurance plan that you choose, and the difference is something we as consumers have to pay. And then at the end of the year, that's all reconciled to the tax system, to this tax credit system. We haven't done this yet, so we don't know how it's going to work. You know, at least in theory, this is the way it's constructed. And so the premiums are constructed in such a way that you are limited to, nobody would be paying more than 9.5% of their income towards health premiums, at least in the thresholds below, within these thresholds. So this, again, it tries to get to the issue of affordability, making insurance more affordable for people. And there's also a very important provision for small businesses. So a small business owner can go into the exchange and they can actually sign up for their employees. So these are the essential benefit package. Every plan that goes into the exchange has to have these different services. These are the things that perhaps relate most to what you're interested in. Preventive and wellness services, chronic disease management has to be in there. I'll talk about it in a moment. One of the important changes that have been made is that preventive care in category A and B and for the U.S. Preventive Services Task Force have to be included in all these plans, and they have to be offered for free with no co-payments. So mammograms, colonoscopies, all have to be offered for free. So the idea is to try to move the system more towards a preventive-oriented system as opposed to just illness care. So, okay, so if you look at this chart, I apologize for the complexity of that, but I said that you can choose a plan, and I would encourage you to go onto the Covered California webpage, and you can see how this works. It's right down here. But the bronze plans covers about 60% of the actuarial cost of the estimated expenditures for an individual. So if you choose a bronze plan, you're going to be having, the premiums are going to be lower, but you're going to have higher co-payments, you're going to have higher deductibles. As you go up the ladder here, if you choose a gold or a platinum plan, the expenses paid by the health plan are going to increase 90%. How much you're going to pay is going to be 10%, but the overall premiums are going to go up also. Now, if you're going to get a subsidy, the amount of subsidy is not going to change. So, if you're a lower income family, or if you're a person that you don't use much medical care, you might end up choosing a bronze or a silver plan because the premiums are going to be a little bit lower than they would be if you choose a higher one. Now, we don't know because this is all literally went live just a few weeks ago. We've enrolled about 17,000 people so far in Covered California, actually enrolled. So the enrollment, I should back up. The enrollment started October 1st. The benefits don't start till January 1st. So we're getting people enrolled now so that when January 1st rolls up, people can actually start using their benefits. So some data is supposed to come out within a couple of weeks for us to know exactly who signed up, what the demographics of those who signed up, what kind of plans they chose, how it varies by regions of the state, All of these will be known pretty soon. So the cost of the family, it depends on income, again paid through a tax credit, premium subsidies, premium for subsidies as well as for co-payments. For some people, there actually would be some subsidies for the co-payments as well. A couple things, who is excluded, I mentioned, does not include undocumented immigrants. And there are also restrictions on lawfully residing immigrants who have been here less than 5 years. So you have patients that have been here for less than 5 years. They still not, but they are a landed immigrant, they're a lawfully residing immigrant. They can actually get into one of these programs. They may not be eligible for the subsidies right away for those who have been here less than 5 years. A little bit about how it affects private insurance, and maybe this is something that would be of interest here. This is probably one of the most important changes that the Affordable Care Act made, was what we call a guaranteed issue, which is that if you have a pre-existing health condition, you would be, in the old system, if you're in the individual market, the insurance companies could exclude you, or they could, through underwriting, they can actually determine that your premiums are going to be so high that it's just unaffordable. I'm sure all of you have stories of friends and colleagues who've had these problems. They're tragic. And this is interesting. One of the parts of the act that everybody likes, they really like the fact that the insurance industry now can no longer do that. It can no longer exclude you based on a pre-existing condition. And it is in effect right now for kids, and it will begin for adults January 1st, 2014. So that is a really big change. It limits underwriting. And the other thing, this is again perhaps interest of you, just based on the interest of this particular group, is that what we call rate restructuring. Now, under the old system, the insurance companies could determine your rates, your premiums, based on all kinds of stuff, but particularly your health policy. So I'm sure you've heard patients and families and friends who they apply for insurance and they fill out this 40-page paper with how many times you've been to the doctor, what medication you're taking, and all that, and they rate you based on that. They go through underwriting. So all that's going away. The only things now that they can do is they can rate you based on your age. So the older people can be charged no more than 3 times greater than the youngest people in the plan. So there can be differentials based on age, family composition, and geography. We know that San Francisco has much higher healthcare costs than LA or the Central Valley, so we charge higher rates there. The other thing that we're not going to do in California, but it's a state option, is to charge tobacco users about 1.5 times greater than non-tobacco users. We talk a lot about this in my class, so the ethics and the public health perspective on this. Is this a good thing? Is this a bad thing? There's all kinds of issues related to how do you enforce it. California has decided not to take this provision. We're not going to charge tobacco users higher rates than non-tobacco users. But states have the option to include it. The risk pool is gone. The other thing that's really important is this one. You've probably already seen your patients. Is that young adults can stay on their parents' health plan until age 26. And now, those of us who work at USC, we've had that. A lot of business already did that. I think it's age 25 here at USC. But now it's got to go to 26, and every business has to comply with this. This is one of the areas that the Affordable Care Act affects everybody, not just new people going into the exchanges or the Medi-Cal. It affects basically everybody. So every insurance plan now, employer-based individual, has to have this provision. So we know nationally about 3.5 million young adults have taken advantage of this new provision, so it is relatively popular. Another important change has to do with these lifetime caps, and we probably all have had patients or students or friends or colleagues that have a serious illness, cancer, and then they hit the cap on their insurance premiums, and then their benefits cut off. And either lifetime caps or annual caps. Some plans have one or both, some of them have both. One or the other, some have both. So now there'll be no more lifetime caps or restricted annual limits on coverage. And actually, I had a student here in our MPH program who came down with a very serious case of cancer, and she actually burned. She was a Starbucks employee. Actually burned through her insurance within a 9 months and hit the cap. And actually sat down with her family at the City of Hope, and with the financial services, they actually come and help them think it through. And they actually brought, which is standard procedure at these hospitals, actually brought a bankruptcy lawyer with them to help the family figure out how they're going to handle the situation. Anyway, that's fortunately gone. There's also an interesting change related to what's called the medical loss ratio. This is not getting a lot of attention, but it's very important from my perspective because it limits the amount of money that the insurance companies can spend on non-medical related services like administrative costs, marketing, executive salaries, whatever, all that stuff. So it has to be limited to no more than 20%. Now some plans do pretty well. Blue Cross, Kaiser, they're around 16, 17% already. Others, Anthem Blue Cross is probably closer to 35%. So this is going to really significantly change how these health plans, at least in theory, are going to manage their own business and their expenses. Another area, all these things, when you ask people, you like the Affordable Care Act, they say, no, I hate it. But when you ask them, do you like these different provisions, they say, yeah, I like that. Until you get to this one, the individual mandate. And I know you've heard a lot about this, which is essentially, it's a provision that says that you are required to carry health insurance. And nobody's going to go to jail because you're not covered to have health insurance, but essentially it creates a penalty that you have to pay under taxes at the end of the year if you do not demonstrate that you have some sort of health insurance. You don't have to get it through the exchange. You can get it on your own. You can move through the individual market if you want, but you have to demonstrate that you actually have this. Massachusetts has had the individual mandate for a long time, about 5 years, and it's actually worked pretty well. It hasn't, a lot of the problems that you've heard about that may have come about as a result of the individual mandate have not been seen that much in Massachusetts. They've actually reduced the number of uninsured in the state down to almost 3%. But you can see once it's fully implemented, the rent penalties can be as high as $700 per adult, $2,100 for families, but in no cases would be more than 2.5% of income. So a lot of the controversy around across the political spectrum is, are these penalties high enough to persuade people to go into the individual market, to go into the exchange? Well, if you're a young adult, I'm not going to get sick. I'll just pay this penalty rather than buy health insurance anymore. We'll have to see as we go how this plays out. You can see there are a lot of exceptions, religious objections. If you're American Indian, if you've been uninsured less than 3 months, you'll all be exempted from the individual mandate. If you're incarcerated, if you're undocumented, if your income is below the tax filing threshold, you'd be exempted from the mandate. But this is an area of quite a bit of controversy, and this was in fact the focus of the Supreme Court case a couple of years ago, in which several businesses and states actually sued the federal government and said that this was unconstitutional based on the Interstate Commerce Clause, and the federal government actually argued back successfully that, sort of successfully, that in fact it was constitutional. The Supreme Court held that the individual mandate was constitutional, but not under the terms and conditions of the Interstate Commerce Clause, but that in fact this penalty here represented a tax. It was really a tax. It was really not a penalty. That's the way they interpreted it. And that the ability of the federal government to impose tax is a long-held provision in the Constitution. Therefore, they upheld the constitutionality of it, but not based on the Commerce Clause. There are a few other things I should mention in terms of things that, again, doesn't get a lot of attention, but one of the, I think, the weaknesses of the Affordable Care Act is it doesn't do a whole lot in terms of reducing the cost of care. One of the things that it does is create incentives to establish what we call these accountable care organizations. These are sort of kind of like a modified version of an HMO. Okay, you think of Kaiser. Kaiser is really the best example of an accountable care organization. And an ACO is where you essentially pull organizations together, doctors, hospitals, pharmacists, working to more as in an integrated fashion in which they would agree to provide care to a select number of individuals in exchange for that the individuals have to go into these ACOs, they get their care through these ACOs, and if these ACOs can demonstrate that they're saving money at a rate that's lower than they would have for these same people in a fee-for-service system, then they can keep the difference. These have been set up in different parts of the country and with some varying levels of success, but the idea is to sort of shift our thinking in the way we pay for medical care away from volume-based purchasing more towards value-based purchasing, where we're going to pay these organizations not for doing things for people, but for achieving certain quality outcomes. So these ACOs not only have to show that they save money, but they also have to demonstrate based on achieving 36 different quality metrics that they're actually improving the quality. So these things are just starting. The USC is actually part of some of the original ACOs, and there are others that have developed around the state in the country we want to see. And this is a very important part of the Affordable Care Act, in my view, because it really attempts to try to get to the problem of the cost of care. So what are the problems and the limitations of the ACA? One is that not everybody's covered. I mentioned the undocumented, but how about the people who decide, I'm just going to pay the penalty? What if they get sick? What are we going to do about that? How about the people who, the other 20 million people who, for whatever reason, are still not going to get coverage? So it's not a universal coverage. So a lot of the discussion right now is, were the penalties high enough? What do we need to do about that? What are we going to do in the long run about the state's involvement in this? I mentioned the states are not at risk for the Medicaid expansions until 2022, but after that, some of the governors are already thinking about that. How are we going to pay our share of that? And another big issue is, perhaps more for us in LA, is what are we going to do about the safety net? How are we going to keep funding for our public hospitals and our community health centers and our county healthcare systems? Even some of our private hospitals, along with our public hospitals, are paid in part by a special, you probably heard about this, called the Disproportionate Share Program, which is a Medicaid enhancement program for safety net facilities. And the idea of these disproportionate share funds is that it helps provide additional resources to hospitals that serve large numbers of uninsured and Medicaid patients. Okay? All that money eventually is being taken out of that DIS program in order to pay for the subsidies and the Medicaid expansions. And the idea is that you're not going to need it as much because everybody's going to have health insurance. Okay? Well, that might be true in Des Moines, but here in LA, where we have 1 million people, in California, we have 1 million people who will not get covered, we have a serious problem of how are we going to manage the safety net, as well as trying to figure out how to deal with the health problems of the people who are going to get coverage. So if you're Mitch Katz running the county healthcare system, you have two problems, right? You got to figure out how to hold on to the patients that are insured, that are uninsured now, who are going to get insurance, right? That's one problem. Because now they're going to have more choice. I can decide to go to Cedars or whatever. So we got to figure out how to keep those patients and align our system in a way that is able to care for the undocumented who will continue to come to our county health facilities. So those are two huge challenges. And we don't know exactly how we're going to do that at this point. But the county system is probably in the best hands possible to try to figure that out. In terms of challenges moving forward, in our workforce challenges, we're going to get everybody insured because we have the right people in the examiners, we have enough primary care physicians. Do we have enough doctors? Do we have the capacity to be able to accommodate the expansion of people who now have coverage? The ongoing political challenges, I don't have to say much about that. It's in the papers every day. Ongoing legal challenges. There are additional legal challenges that are pending. The financial challenges, the general economy. We have a $17 trillion debt. Is this going to add to that debt? So all those things are looming in the long run, particularly as we think about entitlement reform for Medicare and Medicaid. There are tremendous logistical challenges. There's a lot of moving parts to this thing. And trying to get all these people enrolled and find them and persuade them to enroll and help them to enroll and understand this is a big logistical challenge. So we're just getting going with that. In terms of integrative care, I looked a little at where I think the Affordable Care Act provides some opportunities for people involved interested in integrative care. Section 2706 of the Act prohibits discrimination against licensed practitioners, including those who practice integrative medicine. So now, as I've spoken to some colleagues about this in the East Coast, they said, this is a part that a lot of people don't know about, but it does provide some opportunities for those practitioners, naturopathic physicians, chiropractors, and others to get involved in health plans, and they cannot essentially be discriminated based on at least this provision of the Affordable Care Act. And also Section 5101 of the law says that all doctors and chiropractors and all licensed complementary and alternative medicine providers are included in the definitions of national healthcare workforce. Very vague, very general concept, but at least there's something in there. It gives people interested in integrative medicine a toehold to get involved in these plans and part of these provider networks that will be incorporated into these plans in the future. So that's about all there is in the Act specifically as it relates to this. Opportunities, toeholds in terms of getting involved, and also innovations in developing, participating in teams of provider groups that could include alternative and complementary medicine. I think this, in my respect, is probably the best opportunity for the expansion of integrated medicine in a long time because of these two sections. It allows practitioners to come into these plans, to participate in teams, and also could not be discriminated against, which means that they have to be paid for their services. Now, all the politics are still there, and this is going to be a state by state by state fight, as it always is for these groups. But I think the Affordable Care Act provides these new toeholds for the future. These are some of the definitions of relating to prevention. There's a lot in here about prevention, which is really good. There's an advisory group on prevention that Dr. Fielding here at Public Health is involved in. And that's supposed to include a fairly diverse group of licensed professionals, including integrative health practitioners. That's important. Again, another toehold. It's places where integrated health practitioners can participate in ways that they haven't in the past. So I think that whether or not these provisions of the Affordable Care Act will continue is unclear, but at least they're there for right now. So in sum, we have, we're literally at the beginning of a long process, long process. I mean, Medicare was passed in 1965, and it was amended 147 times since that time. So it could be, we're going to have to do a lot of monitoring, what's working, what's not, and it's going to be important for everybody to sort of help monitor this and inform each other and our policymakers about what's working and what's not, because there's a lot of moving parts here, a lot of areas where things could not go as expected. So with that, we may have a discussion and answer any questions you might have. Yes, in fact.
I just have a couple questions. First of all, thank you for such a clear and helpful and hopeful presentation and for so clearly stating the challenges. I'm Lynn Crandall. I'm the director of the USC Institute for Genetic Medicine Art Gallery.
Okay.
And at that art gallery, our mission is to bring together public, private, nonprofit, faith-based academic, and media leaders to look at these complex issues of many moving parts, because artists and their creative minds can help meet these challenges of how to increase enrollment, how to manage, and how to use this amazing, abundant opportunity that we have here at USC. So, first question I have for you, are you working with Dr. Darnell Coleman?
A little bit. He's the one that got the outreach grant here.
The $500,000 outreach grant. Are you working with Craig Keys?
No.
Office of Civic Engagement.
No.
These people are working 1990 when Jane Pisano began to prepare for the millennium, moving off the linear production line kind of attitude and treating the unintended consequences of bad policy. Jane Pisano began to get us to think about how we can work collaboratively. So there is a great deal, I think, going on in the community with festivals like Earth Fest, that was 2 Saturdays ago. We have another one coming up that's in association with Dr. Regensburg. The SOS Mentor Group with Rotary Club are putting on a festival. Many people in this room are people who do booths and presentations of their services. So this is how we are reaching out to get the enrollment in. And
We have to be extremely creative and try everything.
we have to get to the people. And I am so personally impressed with the scientists and bench scientists and clinicians that I'm meeting here and the papers that they're writing. But my fear is that it's not getting to the people. So at the Institute for Genetic Medicine Art Gallery, we have our filmmakers, like one right here with camera in hand.
Highest technology.
All right. Thank you.
But
You're great. We have some students that are actually working with Darnell in some of this. So
That's what we want to do. That's where we're going to be able to meet the management
Exactly.
challenges by preparing those students. So
we
need
have
to share-
medical students and public health students that are working.
Right, those are my questions. Thank you.
Thank you.
You know, this slide up here is very interesting, about establishing this council, and they're looking at prevention now. Do you know more about that, especially the part about the funding for the course?
Yes.
Is there going to be additional funding?
We've got 2 rounds of funding for the Corps so far. And there's a 3rd round, one just closed.
Right,
a couple
one
weeks.
just closed.
Right, so, but there's, hopefully there's going to be more. And for Corey is since we have these toeholds through integrative medicine, it may be a really good place for people interested in putting together a rigorous proposal on how you incorporate integrative care into the traditional models. I think this is the time to do it. You got money out there, you got the political support for it. On the other hand, it's incredibly competitive. Very, very. Yeah, sure.
I have 2 more much more mundane questions. The first one, you said something early on about paperwork, and now they're collapsing all those different ways people get into the Medi-Cal system.
Yes.
We won't even be part of it because we actually lose money. It's easier for us to give the care away for free
Yes.
than to participate in the system. Is that going to go, is the paperwork part going to diminish so that maybe
Yeah.
it's worthwhile to actually see the patients? I mean,
We hope so.
so no idea about whether TARs are going to still.
My guess is that it's not now. Now, what is happening, though, and you probably already know this, is the movement of all the entire Medi-Cal program in California toward more managed care plans. So that may be good or bad. I don't know. But I think that's part of the trend. But I think we got to do something about increasing the reimbursement rates. Absolutely.
So then the second question is kind of off that. So we're worried about the health of private practice in the new world, and how we're going to actually get together when who gets the money and how does it get divided up? And is private practice dead? And do we need to create some whole new system? I'm so sorry we didn't get universal health care, which would have made life great, but what can we do to get, I guess, into ACOs, or what's happening to facilitate practitioners in coming together to be in some kind of system that makes sense?
That's a great question, Cheryl. There's nothing like really organized. It's sort of like almost organized chaos. You're seeing physician groups, small physician groups being purchased by larger physician groups. I think that the future of 1 or 2 practice docs is very limited. It's been going away for a long time, and it's going to be gone. And I think you're also seeing more horizontal integration. You're seeing doctors and hospital groups now buying. Even look at USC. It's the best doing. So we're seeing these consolidations that are occurring. It's not just here; it's happening in Stanford. UCLA's doing it. So, and again, those who are integrated practitioners, this is the time to start having those conversations with these people, because you'll be left out. You know, if you don't start doing something now, maybe this is the time to do it, and go in here with this language about, you know, that in terms of what's required. Yeah. It's hard. It's a great question, Joe, but we just have to see what happens.
Is there anything that's organized so people know who to talk to?
No.
I mean, we're all doing the same
It's
thing in
chaos.
the dirt.
It's chaos, and it's worse here than, because if you go to the Bay Area, for example, you know, there's only a few providers. There's only like there's Sutter, and there's only, here there's lots, so it's much more chaotic. Yes.
When you say it's very competitive,
Yeah.
what do you mean by that?
Back to the Picori grant, you mean, or?
I do, yeah.
Okay, what I mean by that is Picori is a funding source for innovation and research on primary care, looking at outcomes research, all right? So there's many organizations who have an interest in seeing if their plan works, universities, the university consortium, private organizations, and a lot of them are developing these proposals. So I think we have two at USC. So I just say competitive in the sense that there's going to be a lot of people buying for dollars on that side. On the provider side, it's sort of like Cheryl said, there's different kind of competition that's going on as it relates to hospitals and physicians. You can see the insurance companies now thinking about buying hospitals. Why would they do that? I mean, why would an insurance company like United be interested in buying a hospital like a physician? Who's their major competitor? If you're United or Blue Cross? It's Kaiser. Kaiser is 33% of the market. And then that's what they got. You got an integrated system of hospitals, doctors, and everybody else. And in fact, to compete with that, a lot of these guys are saying, well, let's come up with something like that. And that's why UCLA and USC are doing the same thing. They're trying to establish a national competitive integrated system of care.
And I guess my follow-up is how do you see the Affordable Care Act relate to USC integrative medicine? How do you see that opportunity? How do people envision that opportunity? You said chaos.
It's a great question. And I have to admit, I don't know, but I think in the few conversations I've had with the leadership of the school and the Keck Center, Medical Center, is that this is the time when they are rethinking, and the same thing's happening at UCLA. Here, they're rethinking primary care. They realize that we do not have a good primary care network because they know that, they've said that, and they don't know what to do about it. To be quite honest, in my opinion. So that's an opportunity for people to, we do, I mean, as I read more about it, I'm not sort of an advocate for it or whatever, but as I read more about integrated care, there is a alignment with the goals of primary care. So this is the time to have those conversations with Tom Jacobs and others to say, how can we get involved in this new system that you're establishing here at USC? Yes.
Two questions, take one at a time. First one, maybe related to what you were just saying. So, besides our efforts here locally in integrated health, there's a national consortium of academic health centers with similar institutes and centers. So, over 55 now, academic health centers, Stanford, Harvard, Arizona, Yeah, so, their annual meeting's coming up in 2 weeks. I'll be there. Last year, one of the leaders of that group really spoke about now is the time for us to move on the policy level.
Yes.
Talk to the state insurance commissioner, talk to, to get integrated health practices that would be covered under the Affordable Care Act. So I'm wondering, after hearing your presentation, is the place to focus such policy efforts, at the level of state politics, or is it more, say, at the insurance companies, or as you were just saying, second question I have is with respect to the goal of these talks and stimulating research at USC and collaborative research, because this is a great opportunity, I think, I certainly had thought before, maybe others have, but including, policy people in our efforts. What can we do from a research perspective? What needs, one of the things that occurred to me, for instance, is you said something like 20% of maybe more, I don't know, the eligible people for Medicaid don't have it.
Yeah.
So where are these people? Are they, is there a role, for instance, for integrative health practitioners, plomotoras to go out in the community somehow? Is this a potential research? I'm thinking of, there's a professor in social work who's going to be going out and working with integrative healers in different ethnic communities to find out who are your uninsured. I mean, I don't know. How can we start to build some research in the policy area with the institute?
Well, maybe other people have ideas about that. I almost bunch, but I think you just need to brainstorm where there's some opportunities to do that. I thought you were going, Mark, looking at the research on, sort of looking at more research on sort of the value added from a health perspective, including integrated care in these delivery systems. That's something which I think Corey might be interested in. I bet some people have already done that, but I think that's something that would resonate successfully financially if the right plan.
Does anyone else have any ideas of policy-directed research that we can start? And who would we approach at USC? I mean, who are the policy researchers? There's yourself.
Yeah, you've got, we do have a health finance and policy center run by Dan Goldman. He's actually in the School of Policy, High School of Policy and the School of Pharmacy. They're over in UPC, so I talked to some people in there about economists.
I know some of the
They don't have to
people.
deal with economists.
I know some of the people over there.
Yeah.
We can talk to them.
That'd be good. I mean, they're sort of a hard customer to
I'm a student in their school, in the
Okay.
doctoral program. So
Good.
they kind of listen to me.
Awesome. Terrific. Yes, sir. Yes, sir.
I'm semi-retarded, so I'm wondering, I would say that because I made it the point you said. I'm wondering, I don't go to traditional doctors, I just go to alternative care,
Okay.
and I'm wondering, is there any type of accommodation for alternative care in this new health plan that's coming on in 2014?
Not explicitly. In other words, there's nothing that specifically provides funding for or accommodation for. Well, all it does, and you may be disappointed by this, all it says is that if you are an alternative practitioner, you cannot be discriminated against in efforts to try to participate in these health plans. That's all it says.
Because you mentioned that there's two laws or bills having to do with like chiropractic and other types of
Yeah.
So,
Right, so if you're a chiropractor, for example, you can go, and this is the way I understand the theory, I don't know what's happened here. You can go to these health plans and say, I want to be part of these new health plans. And they can't say no to you because you're a chiropractor. That's my understanding. Yes?
I'm a state certified massage therapist,
Okay.
and I've been trying to get into Anthem Blue Cross. And I've been going through a 3-month series of emails, faxes, credentials,
Yeah.
and then yesterday they told me, no, it's not included.
It may be, the point you made, it's about license, so maybe on the question of licensure of massage therapists, I'm not sure.
State license.
Yeah.
State, I have a.
I don't know if that's it, but when you talk about licensed integrated healthcare, there's a licensing board for chiropractors, there is a licensing for acupuncturists. I'm not sure what the level of, I'm certified in guided imagery, but there's no licensing board for mind-body guided imagery. I'm not a licensed, I
Maybe
can't
on a
claim to be
national
that.
level.
I don't know.
But you're licensed.
Oh, yeah.
Is there a state agency or state association?
Yes.
Well, they need to get into gear and start working with Cover California, because you're not going to get anywhere across it.
I'm not sure that the licensure that you have meets what they're talking about. Massage tends to be more city generated because there's no minimum standards for what it takes to be a
It's no
massage
longer,
therapist.
it's no longer city, it's state as of 2010.
So you have a board that you
There is a
report
board.
to?
Well, I don't report directly to them, but, well, I do essentially. All my licensing and credentials go through an application process.
So that would be the place to start, is talk to the board, because they're the ones who should be advocating
Yeah.
with insurance companies.
And that would be wonderful to know, because then that would be, where we could, like you say, Jack Woods here or something, get massage therapy into Kent Medical Center, which I think we'd have
Yeah, I
interest
just
in.
wanted to give some updates. My name's Christine Patrick, I'm here at Tech Medical Center, and I've been actively part of the clinical committee for the Institute of Integrative Medicine. We're working pretty strongly right now. It's a very diverse group of different individuals, from therapists, physicians, nurses. And where we're at right now in terms of our approach to writing this ACAD from a clinical standpoint is we have a physician survey that just got finalized. It's being reviewed to the dean, who's going to send it out to all the physicians. So it's going to look at kind of like where the interest is among the physicians and what different therapies they would order. And then the nurses actually have a grant as well. So we're going to be doing a research for with patient survey in terms of surveying patients to see where their interest lies. And our goal is to get at least like 100 to 200 surveys done, and we'll make a poster presentation out of it. So hopefully, I think once we get this data more so official, in the right way, we want to take it to Scott Evans or Tom Jackson, see where we can bring this.
But you should also bring it to the state level, like Mark said, you gotta move this, because you need to have the support from the state. Because you don't want Tom to come in, well, so who's gonna pay for this? I'll do this, but we can't get reimbursed. What's the point?
Another area we were looking at is within the Affordable Care Act, there's the patient satisfaction,
Yes.
HCAP scores. So that's going to be a driver as well, in terms of showing that the patient's interests are there and that it could in fact improve our patient satisfaction scores. But I do like the idea of also incorporating state within it, and maybe even will be some sort of support in terms of reimbursement.
If you can do a study that shows that what you're doing helps to keep people out of the hospital and reduce readmission rates, that's also, I didn't mention that there's provision that hospitals will no longer be paid under Medicare for a readmission within 30 days for the same health problem. So there's a big incentive to keep people out of the hospital. So if you can show that you're helping to do that, that would be something that would get their attention. Yes?
On that last slide that you had, I wonder why chiropractors were stated specifically and not acupuncturists.
Politics.
Is it the politics?
They have a
Period.
really good lobby.
Is that what
Yeah.
They were in Washington during the debates, during the negotiation of the Affordable Care Act. Yes?
I just want to acknowledge the time, Mark, if you want to, soon we're going to wrap it up, and then people need to go back, and then we continue the discussion for whoever wants to stay. But I just want to acknowledge the time for whoever needs to leave soon.
Is there one more question burning out here?
Well, I just his
When we go to Mary, then we'll go to you.
You know about the basis of how this affects small businesses,
Uh-huh.
and, I mean, because, are they still not, how many people do they have to have employed to
Yeah.
ensure?
That's a great
What's the
question.
penalties, and how does this
Yeah.
affect?
My suggestion is, I'll send this, I send this to you. Susan.
Yes.
And then at the end of this, I have some links to some resources. The best resource for all this is the Kaiser Family Foundation. They are terrific. But the short answer to that, Mary, is that, A, if you are an employer with 50 or more employees, and you don't provide health insurance to your employees, then you'll be facing a fine or a penalty. Now, the good news is that 95% of businesses with 50 or more employees are already doing it. So we're not talking about a whole lot of companies that would fall into that category. The problem is really the smaller businesses. And they would be exempt from these provisions, these penalties. They'd be exempt. And for a couple of years, the very small businesses, the startup companies with fewer than 25, actually can get some grants to help them buy health insurance to bring the premium levels down. And we're developing it's called the SHOP. It's a low-income, small business health plan for people to go into. I don't know how many actually signed up for it, but I think it's going to be a very popular position. Yes, sir.
Looking into the future, in your crystal ball, how do you think the Affordable Care Act is going to affect the recruitment of students into medicine to become doctors, to get into this new integrated system, especially when you've got places consolidating, insurance companies buying up physicians groups and hospitals, and what's going to be the incentive under the Affordable Care Act for a student to say, you know, I want to go into medicine, I want to be a doctor, and get into this now machine?
Yeah, I don't think it's, I don't, we never had a problem with the number of applicants, medical school. So I don't think that's going to go down. It might make changes in the type of people who apply. Could be. I'm doing interviews now for the next year's class, and I noticed that people, some of them might, for sure. But I don't think it's going to have a big effect. Me on the margins in terms of the kind of people that can make.
There are certain conservative TV cable channels that are saying that this is going to bring down quality of students applying for medical schools, going to create a shortage of doctors, it's going to be long lines of people trying to get in to see a physician. And, I mean, you know, they're portraying gloom and doom.
Yeah. Well, I mean, the number of medical school slots have gone up by 15%. The biggest problem really in medical education is between medical school slots and residency slots. Because we've expanded the number of medical school slots, but the number of residency slots have stayed the same. So we're going to actually make more competition among the medical school schools. So we have to figure out how to increase the number of residency slots. This is another area of market research. How do we get more students into primary care and into care? I think that's another area of thinking in terms of research.
Thanks for really appreciate it. We have to clear out of the room or
No.
people mill around?
No, you can still discuss. Make sure you check in, please, and if you add it to the mailing list, if you're not on the mailing list, make sure you put your name down. Thank you. Oh, you're welcome, Carol. Wasn't this great?